Um, Hi everyone, thank you so much for joining. Can you guys hear me all right? Um, I hope you can. And please let me know if the slides aren't working as well. And I can just, fix that if possible. Yeah. So thank you so much for coming for trauma and orthopedics. So I'm presenting this with Amir, and I'll be taking the first part of this. So I'll just be doing upper limb for now, and then Amir will be taking over for lower limb, and then we'll be covering surgical emergencies together. Um, yep, so this is just the timeline of all of like the stuff we're going to be covering this semester. So please feel free to come and join other sessions that we'll be having and going forward. Yep, the session overview again, as I said, is upper limb, lower limb, and surgical emergencies that we'll be covering. Um, so the first thing in the upper limb that we'll be covering is carpal tunnel syndrome. So this is the median nerve compression and it's under the transverse carpal ligament found in the wrist. So I do have a picture in the next slide. So I'll be showing you the two canals that basically run through the wrist. So the two canals, one is the carpal tunnel and one is the Guyon's canal as well. So depending on which nerve gets entrapped, we'll see a variety of different, signs and symptoms that the patient experiences that I'll be going through. But for right now, we'll just be talking about the carpal tunnel, and that would again be entailing the median nerve. So a lot of the times when you see carpal tunnel, it's usually with secretaries, typing or something where their wrist is kind of stuck like that. And that would be the repetitive wrist use as a risk factor. Another one would be, repetitive wrist use. Another one would be a wrist fracture because obviously when this tunnel gets squished, the median nerve gets squished as well.
Because like
Yeah.
there's a waiting room, isn't there? So people are joining the waiting room, then you would never know. So
Oh. Sorry, guys. Yeah, we were just figuring out the waiting room. So another thing would be the wrist fractures, and that would again squish the median nerve. Another one that basically comes in every single condition is pregnancy. So obviously the fluid around a joint, especially if it's a compartment inside your wrist, if it fills up with fluid, the median nerve is again going to get trapped. Rheumatoid arthritis and osteoarthritis would just be with the bony eminences that are kind of growing, or like, the osteophytes that kind of start to form around the wrist, increases the pressure again. Diabetes is like kind of a weird one, but I guess it kind of makes sense with like peripheral neuropathy. So we could see the glove and stocking distribution start to appear and therefore affect the nerve as well. Hypothyroidism is just a rogue one. I wish I could explain that better, but I don't know. And acromegaly is just because in acromegaly, all of the joints get bigger and there's less space. So mostly carpal tunnel, if you think about it genuinely, and if you get stuck, it's what causes increased pressure within that tunnel. It's either the bones grow bigger, there's some sort of trauma to the nerve, or something squishing it. So yeah. So this is the picture I was saying. So if I hope everyone can see my mouse. This orange line is the carpal tunnel, and that's where the median nerve kind of runs through. So the pathophysiology would be an increased pressure within this system. Therefore, that decreases the median nerve like vascular flow. So the median nerve just can't conduct. This leads to inflammation, edema, which again contributes back to the problem. You get nerve ischemia and then axonal degeneration. So when you think about the median nerve, then looking at the signs, if we know where the median nerve innervates in our palm, that would be the most easiest way to know what the signs and symptoms are in the patient. So because the median nerve innervates this thenar eminence, a very late sign would be wasting of this thenar eminence, which we can see in this picture right here. If you look at the patient's area right underneath the thumb, we can see it's been wasting away. Paresthesia, which would be burning and tingling, just like diabetic neuropathy, would be one of the signs. Numbness, again, from nerve compression. pain would be radiating from to the forearm and arm, again, because of the way the median nerve travels down. It's worse at night because if you can think about it, you're just using your hand all the time during the day, that the night the pain just kind of catches up to you. And because you start to again lose some of that sensation because of the tingling and numbness, you start to drop objects more frequently. There's weak thumb opposition. So thumb opposition would be this. And yeah, and abduction, which would be this. So those two motor signs would be affected in patients like this. And just one key takeaway is the thenar eminence sensation is normal, which is the only like kind of differentiating one from the Guillain Canal syndrome as well. And just remember that basically it's all to do with the nerve entrapment, and just know the innervations and which part the median nerve covers, which part the ulnar nerve covers. And that should kind of get you most of the way in your past med or quest med questions as well. Yep. So a couple of other tests that you would just want to do examination wise is Fallon's test, which is wrist flexion. So it's that way. And I always used to get confused as to what's flexion and what's extension. So flexion is when you decrease the angle between two bones. So you can kind of see that's decreasing that angle. And extension is increasing that angle. So you're increasing that angle. So, and that's true to any joint. So if you're going to do bicep flexion, it would be that because you're decreasing this angle, and then extension would be that because you're increasing the angle. Anyway, I used to get really confused by that, so that's why I thought I would just pop that in there. And then Tinol's test would be if you keep your arm out like this and you start tapping on the nerve, you would start getting tingling down your fingers, right? And then carpal compression test is basically when you take your finger and you literally press down and you're trying to re-simulate that pressure onto the median nerve. And for motor testing, you want to do thumb abduction, which is away from you. So you ask your patient to just basically splay their hand out. And more likely than not, they're not able to do that. And always remember you're testing like with like. So if you're doing a hand exam, you should never go and squeeze a patient's finger like this because your thumb is stronger than your little finger. So every time you're testing motor function, you would do little to little finger, index to index finger, because that's the right way to do it. And so for thumb, it would be thumb to thumb, because that's the most equal kind of pressure you have with your patient. Apart from that, for diagnosis, nerve conduction studies is key, especially if you're uncertain if the Tinel's test is, inconclusive. You would more likely than not go into a nerve conduction study. And also if the patient presents with an atypical form. So if hypothyroidism is picked up on the first case with carpal tunnel, then you would also want to use a nerve conduction study just to confirm that. One of the most special populations in this whole game is pregnancy, because as you can imagine, you're only pregnant for 9 months. So after you're like kind of past pregnancy, you've given birth to your baby, a pregnant mother's body starts to like get rid of that fluid, her hormones come back to kind of baseline and what they're used to. So it usually resolves after pregnancy, the carpal tunnel. So the to manage a pregnant patient, you would more likely than not have conservative management just to see if pregnancy solves the issue. If not, you go on to a surgical management, which I'll come to. So conservative management would be a night splint, because basically you want to not squish your median nerve like that, and you want to keep your wrist kind of in its neutral anatomical position. So you're going to have something to kind of hold it in place. Activity modification would be, speaking to someone's job and saying, are we able to make any ergonomical kind of setup differences in the way that people kind of use their laptop, use their keyboard? Are we able to, use dictation, something like that? So I think that's another really important bit, especially when it comes to OSCEs, like make sure you ask for a patient's occupation, because that's quite important during any MSK. You want to know the patient's occupation and their baseline mobility, because at the end of the day, you can't expect someone who's, not been able to, like, suppose their arm is always been like this, you can't expect them to be like this at the end of the day. You would have to kind of bring them back to their baseline. A local steroid injection can help, but again, this is short term because you don't want to be injecting that joint consistently because it can just lead to a variety of problems down the line. Surgical is the only like kind of permanent fix if nothing's happening or if it's an atypical presentation. So you want to open or endoscopically release the transverse carpal ligament. So if we go back to this picture, let me just have a look. Where is this? So the carpal ligament kind of runs somewhere on the top right here. So you just want to release that to relieve the pressure, to relieve the, relieve the pressure, relieve the edema, and therefore give that median nerve more space to kind of heal and not feel like it's squished down. Yep, and then the indications again would be the thenar wasting, which is quite a late sign of a median nerve compression, and if conservative therapy doesn't help. Right. Moving on to the next case. Sorry, I'm just going to quickly check the chat. If anyone has any questions, also feel free to unmute if you do. And if I'm going too fast. All right. I'll just be moving on. So a rotator cuff tendinopathy. So when we take the last word, tendinopathy, it's inflammatory. So it's an inflammatory change to one or more of the rotator cuff tendons. And basically, when you get the tendinopathy, you can also get something called an impingement syndrome that comes with it, which I'll be going on later. So usually this is from an overuse. It can be either acute or chronic, and it's just a degenerative change. So if you think of something like osteoarthritis, it's just that, everything gets a bit old, everything gets a bit squeaky, and nothing works as well as it used to. So therefore you get inflammation within that tendon. You can also get subacromial impingement syndrome. Basically, under the acromion, something gets stuck. That's the easiest way to remember that. And then we can always get a referred pain over the deltoid region, because if you think about one of the special tests, which is a painful arc test, your deltoid is doing most of the, kind of movement of you like getting to above your head. So that's why the deltoid will be the most compromised, most painful, and also worse with overhead activities. So the painful arc test would be the most early sign of seeing if someone has any inflammation within, within this joint. And then the empty can test is also another one. It's also called Job's test. But basically what you want to do is you want to ask your patient to move in front of you 30 degrees from your midline, turn your hand around, and then you as the examiner will push this patient's arm down as they are trying to oppose your force. And then you will feel that they have immense pain right here. And that's one of the most, the easiest way to actually also anatomically know which muscle in the rotator cuff is impinged. So for that test, the subscapularis will be the most impinged. And that's also one of the most easiest ones to tear. Which brings me on to my next point. So a tear would be either a minute tear, like a small tear, or a big tear. And it often follows the kind of chronic degenerative change of a tendinopathy. It most commonly involves the supraspinatus, which can be tested by the empty can test. And also infraspinatuses are commonly impacted along with your supraspinatus, and that's with baseball throws or any ball sport. So you can think cricket, I don't know, whatever you throw, basically. You in young adults or after a fall or dislocation. So I think this is also where a patient's age, especially in orthopedics, matters, and their baseline mobility. So a lot of their decisions, if they're younger, they would most likely, instead of conservative treatment, they would be rushed into surgery, and that would be done first line. If they're older, conservative, and then they might or might not go into surgery. But if they're older with a good baseline, especially when it comes to hips, surgeries of redoing the whole hip is more preferred over just half the hip. But Amir will get onto that later on. Yeah. So to deal with a rotator cuff tear, you can again do two things, which is conservative or surgical. But the clinical features of that would be sudden or severe pain, especially if it's traumatic. You can just imagine just like a tendon being ripped from your arm, like it's gonna hurt so much. So it'll be a sudden sharp pain and a loss of strength, especially over like taking your arm up. A degenerative change would be chronic, so it'll be a mild, longer period pain, which will start to restrict a patient's motion, but not as sudden as an acute pain. The way you diagnose this is a positive drop arm test. So this is kind of a niche one. You basically, as the examiner, you ask either the patient or you passively move their arm into abduction 90 degrees, and you ask them to slowly lower their hand down. If they can't do that and they just go like that, that's a positive drop arm test. But if they can, then you're more likely looking at a tendinopathy or tendinitis. The way that you diagnose this, like in a very like gold standard, would be an MRI. Here in the UK, they first do an ultrasound, then an MRI, or they might, if it's acute, first do an X-ray, then ultrasound, then MRI. But MRI is the gold standard, especially if you're planning for a surgical kind of progression. So this is, I just wanted to show you like this. Yeah, this is the tear. So first, it would start with tendinitis, and then it would chronically move on to a tear. And this is where also the impingement, if it's subacromial impingement, would happen right here. And then this would be on an X-ray. So on an X-ray, we can see this tendon, and the distance between the humeral head and the acromion is meant to be 0.1. I know you can't tell on this, and you really don't need to know that. I just read it today. But basically, this is way too small of a gap. So again, it just gets really trapped in there. On an MRI, MRI's white means fluid. So here, this would be tendinitis leading to a tear, which is shown by the red arrow right there. Yeah, hopefully that makes sense. And then we move on to adhesive capsulitis. So this is what's mostly known. Sorry, I don't know if I'm going too fast, so I'm just going to stop for a sec and just see if there's any questions. And I think I'm okay to go ahead. So adhesive capsulitis is just frozen shoulder. It's above 40 years. Women, especially with diabetes in the South Asian population, experience this a lot. So, and it also sometimes is the first precursor to someone who has diabetes. So look out for that as well. It's associated a lot with diabetes, thyroid disorders, especially hypothyroidism, scleroderma, Dupuytren's contracture, which is basically this part of your hand just goes like that, and any of your cardiovascular diseases. Secondary wise, it's a previous shoulder injury, prolonged immobilization, so your arm's just stuck in a position, especially when you get a cast or splint, or a post-arthroscopic surgery. So they basically put two little ports like a laparoscopic, and they look into your joint. So the way that frozen shoulder kind of progresses is through 3 stages. First would be the most painful stage. It's pain and synovitis, which is just excess fluid within the sinus cavity. Synovitis? No. Synovial fluid. That's what I'm trying to say. Yes. And because of that, you have limited range of motion, mostly due to the pain. Then you have the transitional stage where the pain starts to come down, but the amount of fluid in the cavity starts to increase as well. And as you can imagine, it's a very, very small cavity. So because of that, it starts to irritate everything around it, leading to scar tissue, which is your adhesions that form, and the capsule starts to contract. Because I think one thing that is anytime you have inflammation, will like prolonged inflammation, you have scarring. So even if you think about the liver, you have a really inflamed liver, and then you start to get cirrhosis, where it all kind of comes down. And then the last stage would be the thawing stage, and this would be the inflammation starts to gradually go down, and then your range of motion kind of comes back. But again, the thawing stage, it's long. Not a lot of people actually make it to that stage because it just hurts too much, and they want some sort of thing to, like, they just want to figure it out, Yeah, so right here we can just see how the inflammation starts to get higher and higher, and then it starts to fibrose in stage 3 around that capsule and start to contract as well. Yep. So the clinical features would be shoulder pain. So mostly, again, immobilization is a key feature of or a risk factor for frozen shoulder. So my dominant side is my right side. So my left side is more at risk of adhesive capsulitis. It's poorly localized and it might or might not radiate to the deltoid or bicep. But again, you just want to see, that's why shoulder examination is important. Like it's a very clinical diagnosis. So that's why, especially in adhesive capsulitis, you need to have a proper, good shoulder examination. The stiffness is the main complaint of the patient. They can't go through their general day-to-day, especially if you're like, let's say, putting your groceries on the top shelf, like they can't do it. And that's quite like a hindering aspect of someone's life. And this is again why social history matters so much. Who's helping you at home? Is it just you at home? Do you do your own shopping? Yada, yada, yada. And then you also, the way that they basically can't move their hand either in passive or active motion. So especially external rotation, which is that. So opening doors, opening cupboards would be hard for them. And then passive abduction, so abduction over 90 degrees will be a problem. So they can't raise their hand over their head to put things away. It's a clinical diagnosis. Again, a shoulder exam is really, really, important here. And X-ray might be used to rule out like osteoarthritis, maybe. MRI, the radiologist will literally hang up on you. So don't try. Yeah. And then this would just be the inflammation and the scar tissue that starts to form in the axillary region and underneath the acromion. Yeah. So you want to start to mobilize this joint as soon as possible. So PTs are really important at this stage, NSAIDs for keeping that pain down so they can go through physio properly. Intra-articular corticosteroid injections, again, this is a very, very short-term course that people try and take. There's been a lot of debate. It might not be the greatest thing, and they're trying to like kick out steroid injections. But for right now, short-term steroid injections are indicated if the pain's super severe. And then surgery would be only if symptoms persist. And the surgery that they do for this is mobilization under anesthesia. So if you go into orthopedic theaters and they write MUA of right shoulder, whatever, that's what they're trying to do. They're just trying to move that joint so that under anesthesia, so the patient's not in a lot of pain and they regain that mobility within that joint. So they're manually trying to kind of get through that scar and fibrous tissue. It's a self-limiting disease and it usually improves within 1 year. Again, people just don't want to wait that 1 year because obviously who would? And then because you're not able to move that shoulder, anything that's kept still will start to atrophy. So your deltoids will start to atrophy, your rotator cuff will start to atrophy, and that causes longer term issues. And that's also why people just say, please go to the gym, please lift something. You don't have to actually go to the gym, but please do some sort of physical activity around the house to keep those muscles active. I'm just going to be moving on to inflammatory arthritis. So this is a long one. But hopefully I'll try and make it as short as possible. So there are the three types of main inflammatory arthritis that I'm going to be speaking about, but there are other pseudonegative arthritis that you also need to know. So just to ignore the inflammatory arthritis, the pseudonegative arthritis that you need to know, the acronym is PAIR, so PAIR. So that would be psoriatic arthritis, ankylosing spondylitis, idiopathic juvenile arthritis, and reactive arthritis. So if you just remember that acronym, mostly you can get through a past med question because sometimes they just throw in juvenile idiopathic arthritis somewhere there. But to go on to like the main big ones here, rheumatoid arthritis and osteoarthritis is basically what I'm going to be focusing on the most. So osteoarthritis is wear and tear. Think of old people who have excess body fat and just don't want to move. If you move, you're young, you're fit, you're healthy, you're most likely not going to get any osteoarthritis unless you have an injury to that joint. But that is very niche and you don't need to know that. So just think old, immobile, obese. Rheumatoid arthritis is autoimmune. So any autoimmune diseases, women are unfortunately more likely to get them than men. And it's a younger population. So whilst osteoarthritis is wear and tear, rheumatoid is because of inflammation. Right. So just taking osteoarthritis first, basically what happens, if you think of these two as the knee, that's a young, healthy knee. We have a really nice gap between them. As you go on in life and you're more and more, sitting on the couch and not doing the things you used to do when you were younger, these two joints are going to start to hit. And when they start to hit, they start to rub at each other. So for them to start to hit, the cartilage is going to degenerate first. So you have a reduced joint space between your two bones. Because they rub against each other, you are going to get more and more osteophyte formation. And you get this thing called subchondral sclerosis, which is underneath the bone. You get like a sign on an x-ray, which I hope I've put in there, but if I haven't, please do go and look at it. Rheumatoid arthritis is basically the synovial fluid gets really inflamed. They start to form things called a pannus. A pannus can be found on the big toe, I believe, a pannus. I will check that. But there's pannus formation, and also the cartilage and bones, especially in your small joints, are destructed. You'll see people with rheumatoid arthritis having an ulnar deviation. So how I like to think about it is it deviates towards the little finger because ulnar has an L in it. So their hands, instead of it being like that, it's going to be like that. They have a couple of deformities that you might need to know called the swan neck deformity, which kind of looks like that. So this joint kind of goes up and the rest of them kind of slope down. So it looks like a swan's head. And the joints that are usually affected is the PIPs and the MCPs. So the PIPs would be these joints right there. The reason why I'm talking about these joints so much in detail is because that's usually what differentiates osteoarthritis from rheumatoid arthritis in a question. Osteoarthritis is and also rheumatoid is symmetric. You'll get them on both hands quite equally. Osteoarthritis is basically on the big weight-bearing joints, but if you see them in the hands, they will be on the DIP, which are these joints, just the first joint underneath your fingernails. They are on weight-bearing joints such as the knees, the hips, the spine. Anything that's around the pelvis will kind of get affected. Psoriatic arthritis, this is just a niche one associated with psoriasis. And all you need to know is on an x-ray, it'll have a pencil in cup appearance. So basically, if you have two joints like that, and that is your joint space between your fingers, this top joint starts to curl. So it looks like that at the end of the day. I do think I've put a picture in it. I apologize if I haven't, but I will put them in before the slides are sent out. But yeah. This is a really good diagram. I would highly recommend everyone kind of remember this diagram because this is how I basically am able to differentiate between all of the inflammatory arthritis. Amir will be speaking about gout later on, but just go back and have a look at this diagram really well because it's quite helpful. Another thing with both rheumatoid and osteoarthritis is that is that osteoarthritis lasts for less than 30 minutes in the morning. So so osteoarthritis lasts for less than 30 minutes in the morning. So the reason why I say this is because rheumatoid, you wake up and your joints are swollen. So it'll be swollen for more than an hour. And the way to move swelling out is by moving those joints. So that's why when you start, rheumatoid arthritis gets better later on in the day, whereas osteoarthritis gets worse later on in the day. And if you want to think about it, at the end of the day, you're moving more. So you're going to be getting more and more friction in those joints. So it's going to hurt more at the end of the day. Whereas in the morning, you've been sleeping and everything's just chill. Yeah. Another thing is Herberdin's and Bouchard's nodes will always be asked in an examination of the hand and the wrist. And people always get confused as to where's Herberdin's, where's Bouchard's. I don't know. The way I like to think about it is if I touch a hot object, I'm using this part of my finger. So the closest one is Herberdin's. The one just next to it is Bouchard's. That's the way I like to think about it. Hopefully that works for everyone as well. within rheumatoid, it's going to be warm, swollen, and tender joints. Again, because of that inflammation, it's active, especially when it's active, it'll be hot and swollen, and it'll be a boggy swelling as well. With osteoarthritis, again, it doesn't really affect the fingers, so just remember Herberdens and Bouchard's nodes. Again, with rheumatoid, because it is an autoimmune condition, we want to think about the entire body. So we're going to think fatigue, we're going to think anemia, we're going to think fever. All of those things are quite common in rheumatoid arthritis, especially when they have a flare-up of, their disease. Because it's an inflammatory change as well, you will see a rise in the ESR, a positive anti-CCP. So in past med questions, if they give you a positive rheumatoid factor or positive anti-CCP, you click positive anti-CCP because that's the most accurate for rheumatoid arthritis. In osteoarthritis, you don't get any changes and you can only see them on an X-ray. With psoriasis, they might have psoriasis, nail changes in psoriasis, such as pitting of the fingers. Again, it's an autoimmune disease, so just think swollen, tender, might get other extra-auricular factors. And one of the key things that they get is dactylitis, which is a puffy, swollen finger that kind of looks like a sausage. And one other thing is enthesitis here, which is any tendons, so especially the Achilles tendon, that would be very painful for the patient in psoriatic arthritis. And it's HLA-B27 is also a key factor to remember. And if you guys remember the pair mnemonic, PAIR from before, all of those are HLA-B27 positive. Positive. Yep. And then this is just the imaging. So in rheumatoid arthritis, remember it's symmetric. You're going to have narrow joints. You're going to have erosions of the joints and osteopenia. In osteoarthritis, you're going to have four main things. It's called loss, LOSS. So first one is loss of the joint space or joint space narrowing. O is osteophyte formation. S is subchondral sclerosis. And the other S is, I cannot remember. Oh, it's subchondral, SS. Yeah, subchondral sclerosis is the two S's. And then in psoriatic arthritis, it would be the penicillin cup deformity. That's the main thing you need to know. In all treatments of these inflammatory arthritis, we're going to use NSAIDs. Why? Because they're inflammatory. So we want to get the inflammation down. So number one, chuck them on NSAIDs. For osteoarthritis, lifestyle is a big factor because you want to get the patient moving and you want to help them decrease that weight. Because the more weight you have on that joint, the harder it's going to get. But the more muscle you have in your body, the easier your joints are going to feel because your muscle's supporting them around it. For both of the rheumatoid arthritis and psoriatic arthritis, because they're inflammatory, because they're autoimmune, sorry, you want to use a DMARD. So a DMARD is a disease-modifying anti-rheumatic drug. So mostly we use methotrexate. People are starting to use fancier ones like infliximab, but that's when you get to rheumatology. Like you just leave it to the rheumatologist. You don't really touch that. The only thing you need to know is methotrexate is one of the big things there. And steroids, again, for all three of these, steroids are indicated if the disease is severe. So this would be the difference between rheumatoid and osteoarthritis. So both of them do get the narrowing of the joint space and the soft tissue swelling as well. On the right-hand side, when I say subluxation, that's when your patient's hand starts to move into ulnar deviation. That's a part of the subluxation of this patient. And then osteoarthritis would be cartilages is going, you get osteophyte formation, subchondral cysts, and you also get sclerotic bone. That's the other thing. So you can see on this X-ray right here that this, I hope that this is zooming. That would be, this one right here would be a subchondral cyst. Yep, and then these little bits and bobs that are kind of poking out would be the osteophytes that that are starting to form. Right. So now we're just going to be moving on to the elbow. So the elbow, there are two things we need to know: tennis elbow and golfer's elbow. So tennis elbow is lateral epicondylitis. It's the overuse of the extenders. So if you guys remember, extenders is making this angle bigger. So you're going to be flicking the wrist. So that's why they call it tennis, because it's like a backhand shot, I believe. Yep, so it's repeated pronation and supination and wrist extension. So that's why tennis is quite common for that movement and quite common for, kind of the population of people who get this. It can also be idiopathic, but in an exam question, it's going to be someone who plays someone with some kind of racket sport. So the way this presents is it presents in the lateral epicondyle of the elbow. And the pain also may radiate to the extensors of the forearm. But basically, the pain, there's a video that, there we go. So there's a video that I will show you on how you can assess the pain that's emulated kind of around the lateral epicondyle. So one of the biggest tests would be the Cosen's test. And I'm just going to be playing this so everyone can see. So it's positive if you have pain over the lateral epicondyle. And then medial epicondyle is again the same thing except over the medial epicondyle. So before it was extension, now it's flexion. So that's how golfers play golf, I guess. Yep, so it's repeated wrist flexion and forearm pronation. Yeah, pronation. So it's again pain over the medial elbow, and it may radiate down the flexor muscles of the forearm. The way that you assess this pain is before how it was against flexion of the wrist, now it's against extension. That's basically the test that you need to do. And sorry, I'm just going to be using Amir's wrist because this is a common mistake that everyone makes. You need to take the elbow out of this. So you're going to be assessing the wrist. So if I ask Amir to push down against my hand, that's how I would know. But if you let him just do it with his full force of his hand, there's no way that that's going to happen, or bending his elbow. Yep, so make sure to isolate that joint. That's it for me. So now I'm just going to be handing it over to Amir on lower limb. Yeah.
Okay. Is there any questions in the chat? There's no sound apparently. Oh, that was like an hour. That was like now.
Oh,
That was just for the video for the
oh,
yeah.
sorry.
But it's okay because we could see what was happening, so it's fine. Don't worry.
Would you like me to just show it on Amir, or is that okay?
I'm okay because we're gonna have the video on the slides later as well, so we
Yeah,
can always watch
yeah.
it then as well. So don't
Okay,
worry.
thank you.
And also, you did great.
Oh, thank you.
You did really well. Yeah, Harini did amazing. So we're gonna move on to lower limb, right? Got a few author jokes for you. So I recommend hip replacement surgery for men who aren't as hip as they used to be. And then this one. Yeah, good joke. Anyway, so a 70-year-old lady has been on long-term steroids, fell down a flight of stairs and complains of pain in her left hip. She's now unable to walk, and an examination has a shortened, abducted, and externally rotated left leg. But no, it's left leg. So that's a hip fracture. So there's three main features of a hip fracture you should be aware of. First is pain, leg, and someone elderly comes in with those sort of symptoms that has, a risk of osteoporosis or has sort of fallen down a flight of stairs or something, and that's what you're going to consider a hip fracture. And so the first thing you want to do is get after an A2E, you want to get an X-ray with two views. So you want to get an AP and a lateral view. The reason we use two views in trauma orthopedics is because obviously it's because at some point you might not see a fracture through one view, but it's when you take that other side, you can then see the fracture. So it's always good to get two views. And yeah, while you're investigating as well, it's always good to consider the root cause of the fall. So the little acronym, ADNI, aging, drug, medical conditions, and environment. Yeah, and so because you always want to find out why they sort of fell. So if you're in an OSCE station and there's a woman who's coming with a hip fracture, or a man, you also want to consider why they might have come in. And so maybe ask a few questions around what they were doing at the time. You know, do they feel dizzy? Do they feel breathless? All that sort of stuff. And ECG, bloods, medicine review, exactly. So reading hip X-ray, right? So we've got on the side, we've got on the top, we've got our greater trochanter, we've got our lesser trochanter. So this is a right-sided right femur, right? And we've got our femoral head, and then we've got our sort of what's really important to notice here is our greater trochanter and lesser trochanter, and then we've got our intertrochanteric line as well. So that's what helps us differentiate between an intracapsular and an extracapsular hip fracture. And then past that, we've also got our subtrochanteric line. So I'll talk a bit more about that. So this is what we call, so when we're looking for a hip fracture on an X-ray, we look for something called Shenton's line. And Shenton's line is this nice little clean line on a normal hip X-ray that goes from the sort of pelvic bones down to the femur. And so that nice little curve shows that everything's intact normally. Whereas when that's sort of broken, over here, that's when you sort of see the that's how you can see a fracture. So you can see on the top one, on the left femur, there's the broken Shenton line. So it might be hard to spot, but if you just follow the lines around on the right one, and then you follow the line on the left one, you can see that it's broken. And so that's probably an intracapsular hip fracture. And then on this one over here, well, you've got two hip fractures over here. You've got two different types of extracapsular hip fractures, but again, the Shenton line is sort of broken. Again, this is just sort of demonstrating the intertrochanteric line and the greater and lesser trochanter, which is quite important, especially if you're in an OSCE station and you're given a hip X-ray, then you should be, trying to differentiate between whether it's an extracapsular or intracapsular fracture, because then that determines your management. So if it's an intracapsular fracture, you need to consider the Garden scale. So the Garden scale will help us determine what line of management is best. So if you've got a Garden 1 or Garden 2, that means there's not much displacement. So Garden 1 is when there's little fracture, but there's not much displacement. And Garden 2 is when there's a complete fracture, but it's still not displaced. Garden 3, however, and Garden 4 is when you've got complete fractures, but you've got but you've also got displacement of the fracture as well, and the bones. And Garden 4 is when you've got the most amount of displacement. So you've got greater than 50% of displacement. So taking that, then you want to go, then you can understand what sort of management you're going to use. So type 1 and type 2, they just sort of lead a simple fixation. Because there's not much displacement, you're not affecting the blood vessels around the area, which means there's actually a low risk of avascular necrosis. Does everyone know what that is? I'm going to assume you don't, and I'll just explain it anyway. But yeah, so there's that. What happens is when you have fracture sometimes and it's displaced, you can affect the blood vessels around the area, which means there's not enough blood supply to the bone, which means the bone starts becoming necrotic. If you've got a type 1 and type 2 sort of fracture, you've not got the sort of displacement there, which means the blood supply isn't interrupted, which means you can just have a simple fixation. Whereas if you've got type 3 and type 4, you've got that displacement, you've got a risk of necrotic bone, so you just need to take out that bone and replace it. And then you're either going to go for a total hip replacement or a half hip replacement, so a hemiarthroplasty. Okay, so now how to differentiate between whether someone's going to need a total or a hemiarthroplasty? So you're gonna go for a total hip replacement, especially if someone's quite active. So it's not depending on age. Some people might say, oh, it's if you're like 70, 80, you're gonna go for a hemi because they're not going to survive the operation. But no, if someone's quite active, you want to go for a total hip replacement, especially if they're able to walk independently outdoors with no more than the use of a stick. They're not cognitively impaired and they're medically fit for anesthesia as well. And if they're none of those things, then you go hemi. If you go for the management of an extracapsular hip fracture, then you're going to go, if it's in between the intracapsular line, then you're going to go for something called a dynamic hip screw, which we're actually going to demonstrate on the 6th of December at our Scalpel event. So you should be there. But also, if it's subtrochanteric, then you're going to use intramedullary screws. And yeah, there you go. I think the picture on the left over here on A is a intrachanteric, and the picture on the right is more subtrachanteric. Okay, the management of hip fractures. So don't forget your DVT prophylaxis, especially if you're in an OSCE station. Mention DVT prophylaxis. Mention analgesia because it's really painful. So I think they usually give morphine. They also usually do sometimes
They can do spinal.
a spinal tap. There's something else they do as well, but I can't remember what it's called. And then we also had an OSCE station last year where we had to actually speak to a patient who had a hip fracture, and so this was a difficult communication station. She had a hip fracture, and she was just lying in bed, and she had been waiting sort of 48 hours or something for her surgery. And so the communication station was really like trying to address her needs. So like, being aware of, the management of someone who has had a hip fracture, such as analgesia, regular turning in the bed to avoid bed sores, the fact that surgery should happen within 48 hours, but sometimes doesn't because of emergencies and that sort of stuff. That's all quite important in, helping you get the top marks for that CCA station.
And also like eating and drinking.
Eating and drinking, yeah. Not keeping her nil by mouth, especially if she's weighing around. Because you only need to be nil by mouth 6 hours before surgery. And then it's really important after surgery that you try and get them up as soon as possible. So just informing people, if you're counseling a station about, hip fractures, just letting them know that, straight after surgery, we want you to be up and about because we want to, just try and promote that healing. Yeah. Okay, next joke. So what do you call two orthopedic surgeons looking at a chest x-ray? A double-blind study. I just find these more funny than you probably are, but they're for my entertainment more. So, anyway, we move on. So Achilles tendon rupture. So the risk factors of an Achilles tendon rupture are fluoroquinolone antibiotics. It's actually quite important you ask about this because you can get an Achilles tendon rupture 48 hours after taking one of these antibiotics. The only other important risk factor is really family history. So maybe ask about if anyone else in the family had a Achilles tendon rupture. And the symptoms are quite obvious, actually. All the orthopedic symptoms are really sort of obvious. But yeah, sudden onset of pain in the Achilles or calf. There's a sudden snapping sound and sensation, and then feeling as though something has hit them in the back of the leg is usually like the classic picture. And then you're gonna perform this sort of examination, and it's called a Simmons test. So what you do in the Simmons, there's also a Simmons triad, but I haven't got it on here. But a Simmons test is when you sort of ask the patient to lie their leg off the side of the bed. So their foot is off the bed, but their leg is still on the bed. And then you sort of squeeze the calf, and their foot should plantar flex. And if you aren't seeing plantar flexion, then that means there's a rupture in the Achilles tendon. Other things you can do, inability to stand on tiptoes, and then also feeling for that Achilles tendon. And if there's a palpable gap there, then you're suspecting a rupture. So you're going to diagnose Achilles tendon ruptures using ultrasound, and management review by orthopedics the same day. Again, analgesia, and then I've never been asked about surgical the management of Achilles tendon rupture, but non-surgical is a boot to allow Achilles tendons to heal, and surgical is just rejoin disjointed tendon. So move on to ACL tears. So ACL, the anterior cruciate ligament, is a band of connective tissues. It's commonly injured in athletes participating in sports that sort of involve a rapid change in direction. So especially if you're getting a passive question that says, someone was, playing football and they sort of changed direction and they got an intense sort of knee pain, you're going to go, is it an ACL tear? So the symptoms of an ACL tear is sort of acute onset of pain. You might notice some swelling, some instability, some limited range of motion, and joint tenderness. It's actually quite painful from what I've heard from other people. But and on examination, you find sort of swelling, ecchymosis, which is bruising, and you also find deformities as well. And you can also do the important test for an ACL tear is called a Lachman's test. So this is when you're sort of asking the patient to bend their knee. You sit on the patient's foot, and then you sort of pull the knee towards you. And if you're noticing that there's a lot of laxity there, so the knee's coming quite forward, you're going to notice there's an ACL tear. And so gold standard to diagnose an ACL tear is an MRI. As you can see below, you can see that on the left is a normal ACL. So that sort of, you can see the knees quite aligned. There's that connection of the tendon there. And then over here, you can see that the tendon, the ACL, no, so it's not tendon, it's a ligament, sorry. But yeah, it's not sort of joint bone anymore. Next joke, definition of shifting dullness is an orthopedic ward round. So, all right, next one, Baker's cyst. So this is a popliteal cyst. It's a cyst behind the knee. It occurs due to degenerative changes in the knee, and it's caused by a posterior leak of synovial fluid. So your main symptoms are sort of pain or discomfort. You might feel a sense of fullness behind the knee, a lot of pressure, a palpable lump or swelling, and you also might notice you've got some restricted range of motion in the knee. And on examination, there's something called Fuchs sign. So you get the patient to stand fully extended with their knee, and the lump will get smaller. The lump is sort of extended, is quite prominent then, but the lump gets smaller when you flex the leg to 45 degrees, and that's a Fuchs sign. You know what? These people just make up signs and then add their names to them.
Yeah.
Like I could literally have worked that out and just added my name to it, but fine. Here's what it is. Ruptured Baker's cyst, inflammation in the surrounding tissue and calf muscle. So this is when you've got a Baker's cyst that's then sort of ruptured, and you just need to be aware of it because it could be a 1 in a million pass med question. But yeah, you get pain, swelling, erythema, and consider a DVT as well. That's quite important actually. So yeah, investigations. So ultrasound. So that's the first line of investigation to confirm, to rule out a DVT. So not to confirm a DVT, but rule it out. And then you want to get an MRI to evaluate the Baker's cyst. Management. So if it's asymptomatic, you don't need to treat it at all. And then symptomatic, activity, analgesia, physiotherapy, aspirate, steroid injections, and the rest. Moving on to surgical emergencies. So this is the more like sort of nitty gritty stuff. No, like not the nitty gritty, but the more high yield stuff that's really going to come up in exams and pass med and progress test and whatever else, UKMLA. Next joke. What's the difference between a carpenter and an orthopedic surgeon? Carpenters know more than one antibiotic. Go. Right. I'm just laughing at my own jokes. It's actually terrible. I actually found these on the internet, so they're not my own jokes. But gout is the most common form of inflammatory arthritis, and it sort of typically affects the big toe. If it's chronic, it may affect other areas, so sort of ankle, knees, fingers, and like. But it's usually big toe, and that's what you're going to get probably in a UKMLA question. And it occurs due to hyperuricemia, resulting in accumulation of MSU crystals. So the risk factors are actually quite important because they usually like mention some, sort of unhealthy, elderly man who drinks a lot or who eats a lot of red meat, purine-rich foods, and so that's a really key giveaway in the question that is pointing towards gout. So you have genetic risk factors, dietary factors such as purine-rich foods, metabolic syndromes, obviously being quite unhealthy, and impaired renal function means you can't, you're not excreting that uric acid, the urea out of the body. That's what's causing the excess urea to build up, causing the hyperuricemia. So the symptoms, you get an acute severe pain occurring over quite a few hours. So this is quite acute severe pain, and you're suspecting gout, but you're also going to be suspecting something else, like septic arthritis, but we'll get onto that. And then you're also going to notice that this might be swelling and tenderness over the joint. So in terms of the diagnosis of gout, you can make it clinically using your history and your clinical features. So something called the EULAR criteria, European Union of something. I can't remember what it was. No, the European Union League of I can't remember. It's so the EULAR criteria, the European Alliance of Associations for Rheumatology criteria. So it doesn't matter what it stands for, right? It just matters what the criteria is. So it's defined by having a monoarticular involvement of foot ankle joint. So you need to have like sort of one joint that's sort of affected. Previous episodes of a similar nature. So these don't necessarily have to be present to diagnose gout, because obviously if you had to have a previous episode of a similar nature, then no one would ever have gout, because the first gout wouldn't be diagnosed until someone else had gout before. But anyway, rapid onset erythema and male are just some of the criteria to look for. And then you can also arrange serum uric acid 4 to 6 weeks after a diagnosis of gout to check if they've got long-term hyperuricemia. And so it's usually clinical diagnosis, but if you can't diagnose it clinically and you're still suspecting septic arthritis, that's when you do a joint aspiration. And then you sort of analyze the synovial fluid. That's what we're doing here. And so if you've got gout, you're going to notice in your synovial fluid analysis that you've got negatively birefringent needle-shaped crystals with a sort of low to mid-ish white blood cell count, normal glucose, normal lactate. Now pseudogout we'll get onto, but you can see how it's quite different to septic joint, which doesn't have any crystals in it at all, but it has a very high white blood cell count and low glucose. Low glucose because you usually have a bacterial infection, and the bacteria are using the glucose up as their source of fuel. The management of gout, so the acute management is NSAIDs or colchicine, right? And the only reason you wouldn't use NSAIDs is because you've got some sort of impaired renal function, or this person's had recurrent gastric ulcers, then you use colchicine. So if a question is pointing towards that, you'd go for colchicine. Also, if you're giving NSAIDs, don't forget your PPI. So especially in CCA, just mention your PPI with that. They like that sort of stuff. And then there's sort of certain criteria to give long-term medication for gout as well. So if you're having more than or equal to 2 attacks in 12 months, if you've got the presence of tophi, so I'm not sure if you know what tophi are, but you should Google it. And it's these sort of little crystals that point out in the skin and these little sort of bumps, and that's what you call tophi. If they have renal disease, if there's uric acid renal stones, and then also if they're on cytotoxic or diuretics. So especially thiazide like diuretics, they can predispose you to gout as well. And then you give sort of long-term allopurinol, which is spelled wrong there, sorry. Lifestyle modifications. You also want to, if you're counseling someone about gout, you want to tell them to reduce alcohol intake and avoid alcohol, especially during an acute attack. And if they're obese, make sure they, try and lose weight. Maybe refer them to the weight referral management program. Yes, and also try and tell them to avoid food high in purines, liver, kidneys, seafood, oily fish, and yeast products. Another orthopedic joke. If you've got half a mind to do orthopedics, you're overqualified. So, pseudogout, possibly called calcium pyrophosphate crystal deposition disease. Apparently, I didn't know that, but it's also called constinosis. So it's got a few different allies. It's a bit of a mysterious disease, but the pseudogout is quite different to gout because you're affecting the larger joints. So if you've got larger joints affected, but it's got the same presentation as gout, you're thinking, is it pseudogout? Because it could be the knees, the wrists, and the shoulders are the most affected. In terms of symptoms, it's warm, swollen, stiff, painful. Right, okay. And it doesn't tell you a lot because it's quite unspecific symptoms, right? But in your investigations, when you're doing a joint aspirate and you're doing your synovial fluid analysis, it's going to show positively birefringent shaped crystals as opposed to the negatively birefringent rhomboid shaped crystals in gout. And you also get, this is a common pattern question actually, you get chondrocalcinosis on the x-ray. And it might also show, loss of joint space, osteophytes, articular sclerosis, and some cultural cysts on the X-ray as well. And that would all point towards pseudogout. Again, management similar to gout. So I don't know how it sort of, yeah. So management. So NSAIDs is your sort of initial treatment, and your second line is colchicine. Septic arthritis. Okay, this is a big do not miss disease. Even if you're suspecting gout or pseudogout in an exam, always mention septic arthritis. Always try and rule it out. Always mention, try and do a joint aspirate just in case, because you don't want to miss out septic arthritis because that's probably a fail. But the most common cause of septic arthritis is Staph aureus. And the sort of symptoms you can experience is a big red hot swollen joint. Wow, that's really unique. But the only way you can really differentiate is via the synovial fluid analysis and the joint aspirate. Again, fine needle aspiration of joint for gram staining and puncture. And then again, that same little table there, where you've got the high white blood cell count and you've got an absence of crystals. And then the management, so if it's an infection in a native joint, so a normal joint, anyone has, then you give IV antibiotics for 2 weeks, and then you move onto oral antibiotics. And the antibiotic you give is Flucox. But if you ever forget what antibiotic to mention in an exam, you should say refer to the BNF. And if it's infection in the prosthetic joint, send them to TNO, and they'll deal with it. Oh, no, another joke. 3 orthopedic surgeons took 5 days to do a jigsaw and were proud of their achievement. When asked why they were so proud, they said because it said 3 to 5 years in the box. Yeah, just checking if anyone has any questions, actually.
Laughed at David.
There's no questions, there's just laughter. I know there is, like, can't unmute, but if you were all unmuted, there'd be so much laughter here. But anyway, osteomyelitis. So osteomyelitis is an infection of the bone, and it's often really difficult to treat and requires really long courses of antibiotics. It's particularly prevalent in those with diabetes, so it's a big thing. So if a patient comes in with diabetes or peripheral arterial disease, they've got these systemic symptoms such as fever or malaise, they're not noticing joint pain. Osteomyelitis might be something you suspect. And then there's also chronic osteomyelitis, which is, symptoms of swelling, erythema, or pain. And again, patients with diabetes or vascular insufficiency tend to have this type of osteomyelitis. So this is now talking about raised white cell count and high CLP are only present in acute osteomyelitis. In your chronic osteomyelitis, I guess your body sort of becomes used to the infection being there and the white cell count stays normal, which is what I'm suspecting happens. And then doing an X-ray is where you're really going to find out that there's possibly osteomyelitis there. You're going to have soft tissue swelling, osteopenia, bone destruction, periosteal reactions, endosteal scalloping, and new bone apposition. And then you want to give an MRI, as that's the gold standard to diagnose. And then how do you manage osteomyelitis? Flucox again for 6 weeks. I can't remember if that's oral or IV. I wonder if that's oral or IV. But anyway, I assume that's probably oral because they're not going to keep someone in hospital for 6 weeks. But maybe that's something for next time. And anyway, necrotic bone must be removed, and that must be done via surgical debridement. And so that's quite important. You mentioned that if that comes up in an exam, it's a joint management between surgery and antibiotics. How do you hide a £20 note from an orthopedic surgeon? Put it in a textbook. This wasn't I'm not most proud of this joke, but I just had to put in a joke. So compartment syndrome. So this is a condition characterized by increased pressure within one of the compartments, and it's typically caused by trauma, but also can occur due to vascular procedures. So what I mean by vascular procedures is sometimes you get revascularization of an area, and so that sudden blood flow to an area can cause an increase of pressure, and that's what can cause the compartment syndrome. And also tightly applied casts. So these are all things you should look for in an exam question, maybe suspect compartment syndrome. So it's a big problem because it blocks blood supply to the area. You've got increased pressure, you're going to stop blood coming into the area. Blood is important. And if you're getting less blood, it leads to tissue necrosis. So acute compartment syndrome is what we'll be talking about for the next few slides. And this requires immediate intervention to prevent permanent damage. And chronic compartment syndrome, it usually affects athletes and is induced by exercise. But, we don't really care about that today. So we can talk about acute compartment syndrome. And so the main symptoms are the 5 Ps. So you get pain, pallor, paresthesia, perishing cold, and pulselessness. So you don't need all 5 of those, but it's just, those are like a sort of guideline. Pain is usually disproportionate to the amount of injury that this person's had. And so if that's one of the symptoms, you're going to suspect compartment syndrome. Pulselessness, I usually get sometimes confused because on a password question, they usually say, this patient had this intense pain, but they've still got a pulse. And so I thought, okay, well, it can't be compartment syndrome then. But no, pulselessness is just a sort of late sign. And just because there's a pulse doesn't mean there isn't compartment syndrome. Not all 5 Ps need to be present. And then also consider if, you've got tight swollen muscle compartments, you've got a decreased range of motion, you've got distal neurovascular deficits. That's other reasons consider compartment syndrome. We're going to move on to this. So this is what we got in our CCA station last year. Nikita, since you're the only year 4 here, do you know what this is? Do you want to unmute yourself? Oh, she's not unmuted. fine, is what it is. Right, Nikita, you've been let off. So this was necrotizing fasciitis, flesh-eating disease, which is quite a cool name. But yeah, it's a medical emergency that's difficult to recognize at times. Because I remember in the CCA station, I was kind of confused whether it'd be a Stephen Johnson syndrome or something, but I got it in the end, so it's necrotizing fasciitis. But it's a rapidly progressive soft tissue infection that causes necrosis of the subcutaneous tissues and fascia. And it's got a really high mortality rate, so it's really important to recognize it nice and early, so we can take them into surgery and start treating them. So type 1 is what is most common, and again that's most common in diabetics post-surgery. And then you've got type 2, which is caused by strep pyogenes. So risk factors, big risk factor. I'm only going to mention one risk factor because that's the only really important one. It's diabetes. 60% of patients with NF will have diabetes as well. So it's really important. The clinical features, again, pain, redness, swelling. Wow, same picture as before. But and it also looks like the flesh has been eaten, so it stands to its name. Flesh-eating disease. But on examination, you'd get rapid progression of lesion. So your redness, the red skin is sort of growing over time. And you might also notice skin crepitus. So that's where the air underneath the skin is being produced by the bacteria. And that's an important sign for X-ray, because as the bacteria are sort of eating the flesh, they're producing air, and that is what's causing subcutaneous emphysema. So investigations. So there's a sort of criteria which I actually never knew about, but you can learn if you want. I didn't learn, haven't learned, and will not learn the criteria. But if you just sort of understand generally what's in the criteria, that can help you. And doing a wound culture is good. X-rays, that's when you're going to get subcutaneous emphysema, and your CT and MRI can help diagnose your necrotizing fasciitis, because you'll have fascial thickening, so thickness of the connective tissue. You'll get fluid collection, again, that gas being produced. So here's your X-ray showing your subcutaneous emphysema. So you can see that sort of this grey sort of skin, and then you've got a nice sort of blackness underneath the skin there, and that's where your air is, and that's when you're suspecting necrotizing fasciitis. Big past question actually there. So management, this is quite important. So surgical debridement, that's really the mainstay of treatment here. You're going to constantly take the patient to surgery to debride the infected tissue, to remove the infected tissue, dressing again, and then taking back to surgery as it grows again, and then continue. What they usually do is sort of draw a line around the lesion and make sure that the lesion isn't sort of spreading. But yeah, antibiotics, it doesn't matter really which one. Well, it does, but it doesn't matter to you which one it is. Like, you don't need to learn which antibiotic it is, but it's just antibiotics according to local guidelines. And then if you're like sort of in a CCA station as we were last year, trying to manage necrotizing fasciitis, mention proper dressing care, analgesia, proper hydration, especially if their topmost layer of skin is coming off, they're going to be losing a lot of water. All that sort of stuff is really important to mention. And then also look out for sepsis. So if you're getting the low blood pressure, you're noticing end stage shock, end organ shock, end organ hyperperfusion, then that's when you're sort of noticing that you're starting sepsis 6. Sepsis 6, give free, take free. So let's do that. So give free is antibiotics, fluids, and oxygen, yes. And take free is your urine samples. You can take lactate and blood cultures. So brilliant. That's a joke. A small group of orthopedic surgeons have learned that there's more than one antibiotic. The hospital pharmacy, however, is not concerned, as they can't spell them. Anyway, I'll move on to Harini. He's going to talk about cardiopulmonary. Does any questions? There is no questions. Oh, sorry, Nikita. Apologize.
Hi guys. Yeah, so we're just gonna be wrapping up with just one of the last surgical emergency in orthopedics. So it's called Aquinas syndrome. So this is the compression of the nerves between L2 and S5, and it presents as a lower motor neuron lesion. So and it just basically affects, how I like to think about it is hips down, it affects everything. Fun fact, the reason why it's called cauda equina is because the the L2 to S5 represents the horse's tail of the spinal cord. Equine is horse. Anyway, yeah, the most common reason why people can get cauda equina. So again, you want to think of the nerve roots coming down the spine, and the only way that these nerve roots can get compressed is by a couple of things. Number one, trauma. Number two, something growing in there that shouldn't be growing and exerting pressure. Number three, something that is misdirected and pressing onto it. And a couple of other things is infection. An infection can just cause inflammation and cause the thing to compress on itself. And a hematoma is, again, another mass. So a tumor will compress the spine. Trauma will push the spine, like push the bones of the spine onto that spinal cord. Spinal stenosis, you're narrowing that canal, causing compression of the spinal cord. Infection, same thing, inflammation and hematoma. If a disc herniates, if a lumbar disc herniates, which is basically the discs between the bones that stack in the spine, if that pushes onto the nerve, that directly cuts off, all of the communication in the nerves. So how does it present? So a patient will come in with severe lower back pain, and this is not always the case. Even if a patient does not have severe back pain and they complain of saddle anesthesia or loss of that bladder and bowels, that is a red flag. Like, you just put down everything you have to do in life and you call up Salford Royal and beg for them to take this patient from you. You'll get bilateral sciatica, so basically pain radiating from the back of your hips all the way down your legs. Saddle anesthesia is basically, again, if you sit on a horse, the place where, the region, your inner thigh, your genitals, all of that, which touch the carriage where you're sitting, is going to be basically numb. And again, that's the fun fact with the cauda equina. Bladder and bowel dysfunction. So the L2 to S5 basically control everything below the hips. So you're going to wet yourself, you're going to poo yourself. So all of that is, again, very concerning, especially as a patient who doesn't know what's going on. Lower limb weakness. So this would be asymmetric sometimes, but again, yeah. And then reduced or absent reflexes. So every lower motor neuron kind of affects. So with lower motor neurons, everything is depressed. So you would have hyporeflexia, you would have weakness, you would have, I believe, wasting of the muscles as well. So things like that. But again, it's very acute. So the two main things I would say to take away is saddle anesthesia and any bladder or bowel dysfunction. Yeah. Progressive lower limb weakness is another red flag, and a severe neurological deficit is also, something to kind of look out for. Why this is an emergency? Because clinical suspicion is key. The investigation of choice, the gold standard is an MRI, but genuinely, you're not going to get that in time. You want to have that suspicion, and you want to put the patient on the red flag back pain, cauda equina, algorithm as soon as you possibly can. And the way you want to manage it as an F1, as a junior doctor, is you want to basically symptomatically treat it. So if I am in severe pain, what am I going to do? I'm going to stick this patient on some pain meds. If I am weeing myself, what am I going to do? I'm going to stick a catheter in there. Do you know what I'm saying? So those two are the main things. And then obviously surgical decompression. And with any of these emergencies, one of the main things you say is escalate. You want to escalate because you're not in charge of this patient at the end of the day. It's not your headache. It is your headache, but not really. You want to call up your reg and you need to be like, boss, you need to come down and see this patient because you can't do it alone. And the mainstay in treatment, the management of this is a surgical decompression that has to happen within 48 hours, ideally. And after that's been done, physiotherapy for this patient to regain mobility, movement, sensation of everything that's kind of gone wrong. This is a big thing that everyone needs to know. Memorize this, do whatever. I remember there was a saying called tuna fish or something like that for back pain. I will put that in another slide before the slides get sent out. But basically, you need to know all of these red flags for back pain. Age under 20 or age above 50 with a new pain. So why do we care? Really young people, we want to think of malignancy. We want to think of infection. Really old people, we want to think of malignancy. We want to think of infection. Anyone, consider a fracture. Trauma, fracture. Weight loss, malignancy. Fever, chills, night sweats, what do we think? Infection, or in the very, very rare case, TB, if you're in a tropical region. History of cancer, why? Mets, bony mets. And especially if it's a history of cancer, and they might ask you, oh, this patient has new back pain, cauda equina, yada, yada, has a history of cancer. Which cancer is it? It is most likely a prostate cancer. Like, especially in a man, it is a prostate cancer till proven otherwise, because they have the highest metastasis to the spine. Neurological deficits, again, that would be cauda equina syndrome or a spinal cord compression. Why? Due to a malignancy, a hematoma, an infection, like, whatever can either narrow the canal, inflame the canal, or block the canal, or a herniation. Night pain or pain at rest, that is usually due to a malignancy or infection. Because if you think about it, the only way that you get pain is if you move or pull a joint, like, but how are you like really doing that? It's only if you move. So when you're resting, when you're not really moving and you get that pain, that is a red flag. Osteoporosis or chronic steroid use leads to a fracture risk, which again leads to back pain. And IV drug use would be an infection. So an epidural abscess would be a very huge red flag because again, it's reducing that space within that very narrow canal. But those are the red flags that I've basically come out with. Thank you, everyone. We do not have a QR code. We will send y'all a QR code. Thank you so much. I think Amir would also like to say thanks, everyone.
Thank you so much. I hope you enjoyed all the jokes.
Yeah. Thanks,
Please write your
guys.
favorite one in the chat.
Yeah.
There you go.
If you guys have any and all questions, feel free to email us. Email the Scalpel like Instagram or the Gmail, whatever. Does anyone have any questions though? No. Did anyone find Amir's jokes funny? Just put a thumbs up in the chat if you really did. That's
My
all.
favorite joke was when he said no one would have gout because then no one would be diagnosed with gout.
Real. Yeah. We hope you guys have enjoyed. Yeah, we will send out the feedback and whatever. Just to make sure, have you guys filled out the online form? The pre form, just so we have your emails. But if not, just text the Instagram.
We know who all those people are.
Yeah, we know all 5 of y'all. All 3 of y'all.
Yeah.
Thanks, guys.
Thank you so much. See you
Thank
later.
you.
Bye-bye.
Bye.